And we are going to transition now to our two oral abstract presentations. The first will be delivered by Dr. Christina Kozycki, who will be presenting ROSAH, a new dominantly inherited disease causing autoinflammation and progressive blindness. And then immediately after that, Dr. Shilpa Patel will present the intersection between asthma, morbidity, and healthy housing, creation of an interactive health housing map for the District of Columbia. And so welcome, Dr. Kozycki.
Thank you so much. All right, thank you very much. I'm delighted to have a chance to talk with you all today about my work that takes a slightly different approach to thinking about the immune system. But I hope you find it interesting. So by training, I'm a med-peds physician with subspecialty background in infectious disease, and I'm privileged to have recently taken a position at NIAID as an assistant clinical investigator, where I'm able to work with my long-term mentor, Dan Kastner in NHGRI, who is sometimes considered the father or grandfather of autoinflammation. And then I think Gigi Notarangelo, who's much probably even better known to this group, who is also an expert in the immune system, kind of from the converse side of less in immunodeficiency. So together we're working to develop this program around understanding innate immunity using monogenic diseases. And this poster that I'd like to present, or this abstract, is the foundation for that work. And so for some of you who may be familiar with the concept of autoinflammation, people like Dr. Raphael Goldbach-Mansky's work, you might already be thinking of really early onset, even infantile onset of recurrent high fevers, skin rash. But as you'll see soon from this presentation, that innate immune activation can manifest in different forms. And so this was really kind of a genotype first approach that we took, that we found this disease, we knew the gene was involved in the innate immune system, and it has brought us to think about what those things and as a consequence, as you can see, progressive blindness, it was not really kind of the first thought. This isn't uveitis blindness, this is really retinal degeneration. So with that, I have nothing to disclose. So background on inherited retinal degenerations. So as you're probably familiar, they're characterized by a progressive loss of photoreceptors that can be primarily from the photoreceptors themselves or the support network like the retinal pigmented epithelial cells that support those photoreceptors. And they're not uncommon as a whole. So about 1 in 2,000 individuals in the US are affected by them. And you can see there's a number of genes that have been identified. So right now, over 250 genes have been implicated. And they're really organized by phenotype. So this idea of thinking, what is the gene involved? How does that play into the mechanism? Hasn't really infiltrated the classification system, which is true for a lot of the diseases that are out there. And with the treatment for inherited retinal degeneration, the focus has really been on gene correction, either with RPE65, adding in a gene, or thinking about gene editing, which if you are familiar with disease of autoinflammation is kind of fun from our side because there may be role for immunomodulation, and so something to do more than kind of to monitor progress. So with that background, the disease specifically that I've been focused on is known as ROSAH. So retinal dystrophy, optic nerve edema, splenomegaly, anhidrosis, and headache. And back in 2019, a group of ophthalmologists identified 5 families with this dominantly inherited disease caused by heterozygous missense variants in this gene ALPK1. And so, as I said, this is when our group really became interested because our longtime colleague Feng Xiao had recently published a Nature paper identifying that ALPK1 is actually a bacterial sensor for 7 carbon sugars. 7 carbon sugars are an intuitive innate immune ligand because actually humans can't make 7 carbon sugars. So if you really want to say, what's different between us and them to set off the immune system, 7 carbon sugars are a great target. That's what we had. It just, this is a new disease with a gene that kind of falls in our wheelhouse. And so we were interested. We wanted to characterize it more. We set out with this question, could this disease of progressive blindness, which isn't what most of ours are, but could it be an autoinflammatory disease, which we kind of think of as just innate immune activation? So To determine this, we have developed the world's largest cohort of individuals with ROSAH syndrome. So we've recruited 36 individuals from 16 unrelated families across 9 countries. And we systematically evaluated these individuals for features of classic inflammation, kind of tried to better characterize their general features, and then went to the bench to kind of get a sense of what these variants are doing in model systems. And so here you can see just a schematic of the ALPK1 gene. So there's a ligand binding domain, and then kind of a difficult to crystallize linker region, and then the protein kinase domain. And so you can see on the left side, the variants the other group identified, here this T237M, and then a new variant we identified with our colleagues in the Eye Institute. They're both near each other in that ligand binding domain. So this is the area that senses those bacterial sugars. And so we just put those into a model system, and you can just see over here, this is the pointer. You can see it's a simple luciferase assay to look at NF-kappa B activation, and the 2 mutant constructs constitutively have NF-kappa B expression, and so this is suggesting this innate immune activation is, cell intrinsic. So that's certainly in support of what we're thinking, but, can we look at the patients and see anything that supports that? And indeed we did. So this is just one of the patient's CRPs modeled over time. You can see the upper limit goes to 100. And so the CRP can fluctuate. Interestingly, these patients, it can fluctuate a lot. And so if you check on one day, you may be misled by finding a low CRP on any given day. But indeed, if you can check them frequently enough, at the clinical center, we're fortunate to bring people in frequently, have enough blood draws, you can find that they really do have elevated CRPs that go with it, and then just other plasma cytokines and chemokines like TNF, IL-6, kind of commonly associated with innate immune activation. So in our patients, it reflects what we saw at the bench. And just here to describe what we saw in our cohort. So, the eye manifestations that were described by the ophthalmologist, we saw that are indeed there. But what is notable to us as a more systemic group is there were certainly evidence of more traditional innate immune activation systemically that weren't maybe appreciated initially. So CNS inflammation, the S in there, but hepatosplenomegaly, they can get up to 3 kilos in size of a spleen. So, rivaling a newborn baby, esophageal inflammation, some significant deforming arthritis. And so this was part of our work to kind of put this out there and say that indeed these patients have systemic manifestations, and it would be beneficial for them to have a broader evaluation, and we could think about targeted treatment. I think somebody had mentioned the comment about the rheumatologic treatments and this idea, can you prevent earlier? Ideally in this cohort, it would be to prevent the retinal degeneration. That's not our forte, but some of this deforming arthritis, is certainly commonly associated with improvements in biologic treatments. And so this is what our group went after. And so we tried a number of them, TNF inhibitors initially, IL-1 inhibitors, and maybe patients felt a little better, but it was really this tocilizumab, Actemra, the IL-6 inhibitor, that had the most notable improvement. And so you can hear in the eye. So this is what we went after, really. So it's kind of classic features of inflammatory disease in the eye. And so the top picture is just the fluorescence angiography, and you can see the red arrow is indicating where there's leakage of contrast out around that optic nerve, and then the white arrows on the top image are just leakage around the vessel. And then the bottom is an OCT, kind of the ultrasound of the back of the eye, and you can see those black pockets are kind of cystic fluid. That's not a sign of a healthy eye. And so we were really looking for those to improve and didn't see that on TNF or IL-1 inhibitors, but fortunately we saw a remarkable improvement in just 3 months with that. So we were very promising results. So far, it's only been 3 of 3 young individuals. So for older individuals, the disease can get to reach such a burnt out course that you can't really appreciate changes. And so we're limited in who we've measured so far, but we're actively looking to catch individuals at this early stage and kind of be collaborative in making sure we have good objective measurements of response to therapy. And so just kind of to leave you with the thoughts that, although this might not look like what you have in your mind is a classic autoinflammatory disease. Indeed, ROSAH really is a disease of innate immune activation caused by these gain-of-function mutations in ALPK1. Again, fortunately, it means that some of these features can be amenable to immunomodulatory therapy. And we're going to have to study further to see the extent of what we can change with preventative therapy. And just thoughts on future directions. So, one of the benefits of a monogenic disease, and this cohort is largely the same point mutation, that is actually amenable to base editing. So this is something that is, a hot area, and this cohort is something we're thinking about for them. There's also ALPK1 inhibitors, because it being a kinase could be a good target for that. And then the idea to expand out the program from here. So certainly actively looking for through cohorts for other variants in along this pathway of where we know ALPK1 signals or other atypical kinases. So many thanks. I mean, the patient cohort has taught us so much, and to many of our collaborators at the NIH. Thank you.
Hi, everyone. Thank you so much for the opportunity to present this work. This is based on, I would say, progression of data, and hopefully I can tell a good story with a lot of people in the audience who have contributed to this work, so I'm happy to present it on the behalf of Impact DC. I am the medical director for Impact DC, trained in pediatric emergency medicine, lucky to work with Impact DC in asthma for the past 7 or 8 years, and have really loved our approach in Impact DC, and hopefully I can share that as well. I have no disclosures. So just to create some sort of a background in terms of backdrop to why we want to take this approach to asthma, I'm going to present Dr. Tyrese's work, and Dr. Gauri Shankar, who's a co-author of this paper, is also in the audience. What they did here is they overlapped asthma at-risk rates in Washington, D.C. with social determinants of health. And this map actually shows the difference between looking at just hospitalization rates across the city by census tract and looking at-risk rates. And essentially, you could use at-risk rates are a little bit better at differentiating difference in prevalences across the city. So when you overlay at-risk rates with social determinants of health, perhaps you have a way to kind of say, what are the reasons there are disparities between this area and that area? And this work is kind of important to kind of show that there are differences, and where potentially there are differences. They did find that housing vacancy, crime, educational attainment were associated with that overlap of social determinants of health and at-risk rates. And that kind of sets the background to kind of what we're looking at. And when you think about social determinants of health and pulling out neighborhood and physical environment, we know from multiple studies that housing is a significant social determinant of health and a key driver in asthma health disparities. We also know that poverty plays a role, and impoverished communities are more likely to live in low-income housing. Low-income housing are associated with higher unsafe, healthy asthma exposures, and this could contribute to the asthma disparities. And this came up earlier. Although the asthma rates overall are plateauing, the disparities are still present. So 1 in 8 non-Hispanic Black children have asthma compared to 1 in 18 non-Hispanic white children. This is from the most recent CDC data that they have published on prevalence. And looking just back at like kind of our data in Impact DC, Dr. Ankur Shah, my predecessor, looked at just Impact DC data. We asked very clearly, Impact DC is a multifaceted program started by Stephen Teach approximately 2 decades ago now, that works in the community, works really closely with the schools, really closely with the families, the primary care providers, to really provide a comprehensive approach. One of the things we do is we do a housing screen. So Dr. Shah essentially looked at the housing screens for 3 years of Impact DC data in terms of patients who had housing triggers, and the ones that we actually were worried enough about to send landlord letters to, in terms of the landlord to kind kind of make changes and overlapped them with poor asthma control. So our asthma control test that we also collect at the same time, and saw at the zip code level, a correlation between poor asthma control and unhealthy housing. What we want to do is a more precision public health approach with this interactive map. So we don't want to look at the zip code level, but we want to actually look at the housing level, the unit level. Can we identify these children, where they live, the actual units where multiple children live, and do something with a broader sweep instead of one house at a time, which we typically do in Impact DC right now. When family comes in, they tell us they have housing triggers. We address them in many, many different ways, working with our legal partners, working with our housing intervention partners, the landlord, providing education so the family can do what they can to control the asthma triggers in their environment. So the objective of this project was to develop an interactive, dynamic, public-facing, healthy housing map that leverages lots of data. So data on housing conditions, and then data from pediatric asthma outcomes for multifamily housing units in the District of Columbia. The data sources, we have our emergency department utilization. This was pulled from our novel Children's National Pediatric Asthma Registry. This is a population health tool that has a 90% capture rate based on CDC data of all 16,000 children who live in DC. We know exactly where they live. We know what medications they are on. We know their utilization rates. So it's a very comprehensive source of data, and that was input into this map to essentially provide the ED utilization rate. And then in terms of the asthma-specific housing code violations, multiple different sources, both are publicly available and our own from our own clients, which is not publicly available data, was pulled into this map. So our housing and legal partners, Children's Law Center, YAHAD, our housing, their client databases in terms of the different housing triggers. Impact DC's housing screen that we have to a lesser degree was pulled in. And these triggers were categorized into big categories. So whether it was pest infestation, mold, water issues, kind of big, huge categories. And the reason for that is also when we pulled in the publicly available databases, when we looked at the housing code violations from the DC compliance and regulatory affairs information, the tax credits to kind of identify which housing units belong to one landlord or one developer. All of that we also categorize in the same exact category. So when we looked at those housing code violations, we wanted to match not just by address, but also by the categories with our data. And then we kind of identified which are these housing units, and which, even though one housing unit may have 20, 25 addresses, we needed data to kind of group them as one so that we could look at it as a housing unit level together. These are our housing map inputs that I was talking about. So the Children's National Registry, which had the ED utilization data, the Impact DC housing social needs screen to a lesser degree, but whatever screens we could pull in terms of our clinic data for patients we actually saw and identified housing triggers, we put them there from there. Our legal partners, our housing partners, and their client databases. So we pulled unique housing triggers hazards from their database and categorized them into these big categories of mold or leaks, pest infestation, and then looked at the public data on the other side. You can see on the right side from the DCRA housing violations, Superior Court data to kind of corroborate some of that data, tax information. So for subsidized units, you could actually kind of decide who was the owner for multiple addresses. So you could group these units together into multifamily housing units and 311 requests by families. And this is all publicly available. The DCRA has a unique tool that you can actually go in and look at the city violations at the city level, and that's the data. And it was a long and cumbersome process that Gina Dwyer and Kida Kutcheru went through and cleaned the data to make sure that what we were getting is what we wanted. Part of that cleaning was thinking about which residential units do we want to include. We want to make sure that we're protecting patient privacy because we were going to be overlaying asthma data, utilization data on it. So essentially we limited residential units that in terms of the asthma numbers were 3 and more. And then in terms of no units that didn't house less than 5 people, about 95% in the entire data set lived in these rental properties in the box that you can see. And those are the ones that we included in the map. This is kind of a demonstration that apartment complexes may have multiple addresses. So when we're geocoding based on the asthma utilization data, we needed to kind of put them together into units, like housing units, so we could actually pair the housing code violations to that management company or whatever to the patients that we were attributing it to. And so this was also a process looking at the tax data to kind of understand which of the units actually fit together into one unit. The other thing that we wanted to make sure we weren't doing is we weren't taking skewed data. So we have some patients in our asthma registry who visited the emergency department, let's say more than 8 times in a year. So we wanted to kind of take out the factor of somebody who maybe just had poorly controlled asthma for multiple other reasons or just bad disease kind of out of the picture. So patients with high utilization who fell out of the kind of the bell curve, they were also actually removed from the analysis. And then the map was published. So the published map is actually quite cool. Anyone can actually go on it and play with it. You can actually remove and add layers. The big layer, of course, is the overlap between the housing code violations and the ED utilization. And then the ED utilization is actually also separated into 3 zones, so low, medium, and high ED utilization based on the at-risk rates at the unit, at the housing unit level. And from just even personal experience, our school partners, so we have people who are actually looking up kids' addresses on the map saying, oh, this child that I'm worried about actually comes from the property that has such a high rate of housing hazards and ED utilization. So I can understand we actually need to do something to help this child. And that was the child that we recently helped. So it's already being used. It's out there. It was actually presented by Dr. Teachin, Nikita Kutcheru, and Gina Dwyer to the Housing HHS Secretary earlier this week, over the weekend. There's a lot of interest. I think the key here is public facing so that we don't even know what other people may find useful in this, but we wanted to create it so that people can actually go through it and interact with it, use the layers that they want to use, and then it has significant policy implications. You can also zoom in, and this is kind of what we're saying. Like, so if you want to zoom into a property, you can actually zoom in, look at the total visits of that we have in there, the property type, who's owning it, which kinds of, remember the categories that we were talking about, which kinds of housing hazards are at this building. Is it just one? Is it multiple? You can actually filter by. So if you want to just look at mold, you can do that. If you want to just look at pests, you can look at that as well. And then if you want to even look at a geographic neighborhood, you could pull up. So the table on the bottom, the attribute table, you can say just in this area, which are the buildings they live there and how do they compare with each other. So you can even just zoom in on a particular area of the map for DC if you want to. Some of the limitations, because we use tax data to group these units together into multi-housing units to kind of identify who the management company was and that it was one. Privately owned data housing that's not subsidized is underrepresented by this map, but it doesn't affect the other data. The housing conditions data reflect what's available. So if it wasn't reported to any of the systems that I put in there, it wasn't in this data. Smaller buildings, because we were trying to taking out less than 5 units to kind of protect privacy, those are also underrepresented in this map. This is where I want to kind of spend most of my time in terms of discussion and next steps, because I think that's kind of probably the coolest part of this. So what can we do with this data from an Impact DC hospital level? We can identify properties or neighborhoods in most need of remediation. So if we wanted to do a demonstration project and study the impact of a large scale remediation on future health outcomes of children with asthma who live there, you could pick 1 or 2, maybe the highest morbidity units with the highest asthma hazards, fund a significant remediation, do a pre and post evaluation of what happens to those kids there. You could also do proactive outreach. So we don't want to wait until they come to the emergency department. The rest of the kids who are living in those units, we can actually be proactive in terms of reaching out to those kids that are living in these high risk units and come in and bring them in for education and the remediation that we already do, optimize their asthma control in every way that we can. We could also refer for large scale enforcement efforts. So a lot of these landlords, a single landlord letter, sometimes when we were looking in the record, it was sent the last time they came to us, we send it again, and that seems less effective. So maybe this map could help prove beneficial in terms of convincing government to do a large-scale enforcement effort of a multi-family housing unit. It could also inform housing policy. So when we're building new housing policy, now we have identified housing hazards, and we could create a checklist for what would be an asthma-friendly home in terms of what we want, what's a good unit look like. And kind of to wrap all of this together, we're really leveraging private and public funds and data to promote building and maintenance of healthy properties to serve as model for the nation. And so we used publicly available data, but I think just this demonstration shows that if a city wants to and has the interest in making this happen, they could actually potentially leverage other data sources that maybe not be publicly available to create a more robust map. So this is the study team, quite a lot of people, lawyers and housing specialists, our specialists from our Impact DC team. Gina Dwyer is a GIS analyst. Nikita Kutchru, those two were probably the most instrumental in this map, along with Dr. Teach. The funding, we were funded by Fannie Mae, and then DC Health Registry, which is one of the big reasons we could actually even do this, was funded by the DC Health, Department of Health, and our collaborators. I'd like to thank YHAD, Children's Law Center, and Child Health Advocacy Institute, the Health Data Lab with the GIS resources. Questions?